You're watching CTOM TV. Knowledge is power.
So immune therapy. This is the new poster child for many cancers. I think there's at least 25 different FDA-approved cancers that have immune therapy. A little primer on immune therapy. There's about 11 or 12 different ways that the cancer cells can hijack the immune system. One of the things with the immune system is that it uses a lot of the same resources as cancer cells. So it works on the same mechanisms. It likes sugars like cancer cells do. And because of that, cancer cells like to hijack the immune system. In other words, once the immune system goes to investigate a tumor, then what will happen is the cancer cells can use, one of 11 or 12 different pathways to shut off the immune system and then use all of its resources. So one of those, we have drugs for a couple of them now. We have drugs for what's called the PD-1 Cascade, and this has been a huge game changer in cancer. We also have some that will target the CTLA-4 pathway. And then we also have a drug called, that targets a pathway called EDO, although it's not that effective yet. We haven't quite figured out how to use it. But PD-1 inhibitors, we were the first to ever use PD-1 inhibitors in Canada. That patient is still alive 6 years later. She was on death's door. She had literally months to live and tumors all throughout her body, and it eradicated them. We've had quite a few cases now of patients that have had phenomenal responses to immune therapy. We look for certain things in tumor DNA sequencing. One of them is called high tumor mutation burden. We also look for something called PD-1 expression. And then we look for other molecular, can you go back for a second?
Okay, sure.
We go through other molecular features that we look at that can determine whether immune therapy is going to work for a patient or not. But even then, there are some things that we don't know. And so, you just never know when immune therapy is going to work for somebody. So if you can go into the next slide. In lung cancer, one of the things that we do know is how much of this PD-1 expression there is. So PD-1 is, you have what's called the ligand that is on the cancer cells, and it clicks into the receptor on the immune cells, which are called CD8 positive T cells. And these T cells, if you don't have this PD-1 ligand, it's a protein on the outside of the cell. If you don't have that, then the T cell will attack you. And so what cancer cells do is they mass produce this PD-1 ligand. So when the immune system comes along to kill them because they're growing too fast and causing havoc, they provide this overabundance of these PD-1 ligands, and therefore the T cell is turned off. And so in certain cancers, you'll see a bunch of T cells inside of the tumor, but they're turned off. So these PD-1 inhibitor drugs, the common one is called pembrolizumab or Keytruda. There's also nivolumab, and there's actually a bunch of them now. There's quite a few different ones. These PD-1 targeted drugs, what they do is they reactivate the T cells, the CD8 positive T cells within the tumor, and then these cells actually kill the tumors from inside out. And then they also make up some antibodies against the tumor. So it's like getting a vaccine almost. You get this long-term memory. And so we've only had these drugs around for about 5 or 6 years, but what we have seen is when they work, they tend to work in a curative long-term remission manner. So, we've just seen phenomenal results. So lots of factors to determine whether these drugs will benefit you or not. The standard care right now is to combine them with chemotherapy and radiation therapy. And they seem to work quite well in lung cancers across the board, regardless of the molecular features. So if you go to the next slide. So some of the things we like to look at is we like to know, it says precision oncology for colon cancer, Michelle.
Oh, I'm sorry. Yep, thanks.
So that's lung cancer. So immunotherapy. So one of the things doctors will look at is they'll look at your PD-1 status. We would also look at that. So if you have low PD-1 expression, then they don't always offer immune therapy drug by itself. But what we do know is that even if you have low PD-1 expression in your tumors, if you combine the PD-1 inhibitor with a CTLA-4 inhibitor, such as ipilimumab, or with chemotherapy and radiation therapy, it works much better. If you have high PD-1, and you can even get benefits just from a single agent immune therapy drug. So next page. So for example, how we like to look at things. This is colon cancer again.
Yes, I just do. This isn't obviously I use the same header, but the information is specific to lung cancer.
So if you have high PD-1 expression, you can use pembrolizumab or nivolumab. Nivolumab was the first generation PD-1 inhibitor. Pembrolizumab is kind of the second generation. And they work by binding onto the receptor of your T cells. And so therefore, it doesn't matter if the cell has PD-1 expression or ligand, it's going to attack it if it's a chemo. And so typically, you can get these with low dose chemo and radiation. Another option is these are kind of the new generation of drugs. I call them the third generation, but they could be considered second generation. Tessalizumab is one of those drugs. This drug binds to the actual ligand on the tumor. So pembrolizumab and nivolumab bind the receptor, the PD-1 receptor on the T cells. Tessalizumab and all of the new, most of the new next generation PD-1 inhibitors actually bind the ligand on the tumor, and they stop the interaction between the PD-1 and something called B7. So there's another drug, semilipilab, which is a new one, can be also used alone. Pembrolizumab or tezolizumab can be combined with low-dose chemotherapy, nivolumab and ipilimumab together. I wouldn't typically suggest it with chemotherapy, but I know there are cases where you can have chemotherapy first and then have nivolumab and ipilimumab. So if you want to go to the next slide. So just the themes that we like to look at, because there's so many different combinations, so because pembrolizumab and nivolumab target both receptors on T cells, it's not both receptors, it's receptors on T cells, there's a typo there. Atezolizumab targets the ligand on tumor cells. Just a summary, so the different mechanisms. So PD-1 plus a CTLA-4 inhibitor for low PD-1 expression. If you have low PD-1 expression, you can also use a PD-1 ligand inhibitor, such as atezolizumab plus chemo. Or if you have high PD-1, you can use a single agent PD-1 receptor, receptor inhibitor, such as nivolumab or pembrolizumab. Okay, but always what we know, and I think this last point is the important one, is that regardless of PD-1 expression, it's best to include multiple drugs. So even if you have high PD-1 expression, it basically means that if you can't tolerate chemotherapy, but you have high PD-1 expression, you can probably get away with using a single agent receptor inhibitor, but it's always preferred to use multiple drugs if you can, including chemo and radiation. Okay.
Thank you for watching CTOME TV. Subscribe below and stay informed.